Yet another neuro talk. Seizures and MS, although I'm really not going to say much about seizures other than to ask you to watch some of the other videos that are available on YouTube. This is specifically one. I'll put the link to this associated on this presentation. But there's some other great presentations on seizure medications, and I'm going to let them explain that to you. So here's a case. George McMurphy, 45-year-old man. He's from northern Minnesota. He was diagnosed with MS about 5 years ago. May have actually had symptoms for 10 or so. He's the manager of a grocery store. Now, the fact that he's from northern Minnesota is actually particularly important. And the reason for that is that MS occurs in the northern portions of countries. It doesn't occur in the south. So the prevalence in Minnesota is probably, I'm just going to ballpark this, but 10 to 15 times the incidence in the southern portions of the country. I'll try to actually get those numbers for you at some point. But either way, you don't see it much in Texas. You see it a lot in Minnesota, Maine, those parts of the world. People that have MS lots of times have had it for some period of time. Often the symptoms precede the diagnosis by a number of years. It's not an easy diagnosis to make. George is in sort of the age group in which you usually see it, although it can be much younger than this and even older than this. George has got a couple of kids, started with his kids a little bit later than some do, and his kids are younger. Recently, George has had some upper respiratory type infection symptoms. What other symptoms do people with MS get? Very commonly, they'll see double. They'll have diplopia. Usually that's because the eye muscles aren't coordinated. And the other thing that can happen is they'll actually start to have almost like uncontrolled or more spastic type movements in which the muscles contract in a less organized fashion. Again, they may have noticed mild changes for years before they're fully diagnosed. Bladder may actually not contract as well, especially in a 45-year-old man. We're assuming that he's probably got prostate issues. But if we check a post-void residual on him, it's likely to be pretty high. And so we need to keep our thoughts available that, geez, maybe he's got something else going on. So what happens in MS? Well, usually the patient will lose their myelin sheath. So here's the myelin sheath on a normal person. You get a nerve impulse. It goes boom, 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 and goes down very quickly. If you've lost that myelin sheath, it goes down here, boom, and then kind of struggles. And that's why if you've got demyelination of the left eye but not of the right eye, you'll have slower movement of those extraocular movements on one side and thus get diplopia. Other parts, you'll get demyelination, you'll get decreased strength, you'll get decreased bladder contraction, lots of different things that can happen associated with this. So these folks are a bit more likely to get pneumonia. They're a bit more likely to get UTIs due to urinary retention. People can sometimes only have a single episode of MS. They may actually have a progressive version of MS. The most common is relapsing and remitting MS. It's a pretty unpredictable pattern, though. Some people have flares frequently. Other people get them every 10 years. So it's a very difficult disease to treat. It's a very difficult disease to understand. Some of these people will get an intention tremor. Most common cause of intention tremor, obviously, is benign familial tremor. So often these folks will have been diagnosed as that. They, however, will often start to have ataxia. They'll start to have diplopia. They'll start to have other changes. What can we do for MS meds? Well, most of the MS meds are immune modulators. They basically are chemotherapy type medicines. They slow that demyelination down. Most of the people that are using those kinds of meds have so-called secondary progressive MS. People that have relapsing and remitting MS usually use an interferon type drug. And these are gradually being replaced by biologics. But you know, the ABCs of MS were Avonex, Betaseron, and Copaxone. Those are still used. But as we note, the biologics do seem to be gradually replacing those. So I'm going to do a separate talk on biologics. I don't have it ready yet, but I hope to have it ready soon. But one of the most common biologics used is Tysabri. And Tysabri, basically, like all biologics, creates a monoclonal antibody, an MAB, which basically interferes with some sort of an autoimmune process. So in MS, the patient is attacking their own nerve cells and demyelinating them. And so if we can block that process, we can prevent the symptoms. There is the risk of PML, progressive multifocal leukoencephalopathy. There is a virus that's called the John Cunningham virus. And unfortunately, if you have this John Cunningham virus, you're more likely to develop this PML. Therefore, lots of times they will test for the John Cunningham virus before they put somebody on these medicines. But once they put these medicines on, it does keep the white blood cells out of the blood-brain barrier, so it does decrease that demyelination and does substantially improve their outcome. Gilenya also has a similar mechanism of action. It is a biologic, but it's in a sort of different category. It is a medicine that can cause QT issues, though, so keep that in mind. Steroids are medicines that when a patient with MS flares, they will get what I think of as massive dose steroids. So when we think of Solumedrol or Solucortef being 80 to 120 milligrams, these folks get 1,000 milligrams on a regular basis. So they get very high dose. They seem to tolerate them well. Most people get pretty good response from them, but they're really only used for flares. And obviously they have the same side effects of long-term steroid use that someone would get. Very quick and dirty on MS. You know, I'll actually probably redo this talk next year to try to expand it, but I think it gives you the basics.